Good morning, everybody. Since we are running out of time, I will talk on the surgery that the principal advantage of which is it takes less time. Nil financial interests. So the objective of the talk is to review the causes of retinal detachment in a silicone oil-filled eye, revisit the indications of a surgery which is now performed quite less often, so under oil surgery, look at the surgical pearls, and just analyze how the patients do when you do under oil surgery rather than removing the oil. So briefly, if you look at the causes of recurrence under an oil-filled situation, it could be with PVR or without PVR. With PVR, it could be an anterior PVR, could be a posterior PVR, or could be a combined anterior and posterior PVR. On the other hand, without PVR, we could have a single leaking breaks, could be intrinsic retinal contractions, or could be a posterior slippage of the giant retinal tear. So in a nutshell, if you look at an oil-filled eye, the commonest cause of recurrence could be a PVR, followed by leaking retinal breaks and intrinsic retinal contractions. Before we jump onto the cases where we can do under oil surgery, we must be very clear the situation where oil removal is must. It's a cases like recurrent RD in a phakic eye where we prefer removing the lens to do maximum removal of the anterior cortical gel and to remove all the anterior membranes. Combined anterior and posterior PVR where we need to do good aggressive base dissection to stabilize the retina, and obviously extensive subretinal proliferations where we need to do large retinotomies that is really not possible in an under oil scenario. So under oil surgery is basically can be done in a few selected cases like focal posterior PVR, open breaks, single open breaks in the periphery with no PVR changes, and posterior slippage of the GRT. So looking at the video, one illustrative case, it's a case of a focal posterior PVR. Basically the principles of membrane dissection are essentially same in all other surgeries like this. Here there is a focal posterior PVR which is being teased with a spatula. The important thing is to remember is that moment you make sclerotomies, the oil starts leaking out. So you have to keep on injecting oil intermittently to keep up the pressure of the eye to prevent hypotony. Rest of the things are essentially similar. We tease with a spatula, then pull out with the forceps. One more important thing to remember is, before we start the surgery, we must be very careful to remove all the saline in the anterior chamber, over the ONH, and at the junction of the retina, detached retina, and the silicone oil to remove the interfaces which improves the visualization. Sorry, I want to go to the next video. There is another video. Yeah, this is another video which shows another case of recurrent RD where there is basically a single leaking break in the periphery. Here basically go inside, look thoroughly 360 degree to find whether any other breaks are there, and here you localize a break at this end. You do a little cautery, go in with the fluid, suck out the fluid, and do good laser around it. And after you complete the laser, you can go and look at 360 degree at the laser sites, because most often than not we can find tiny breaks that are formed at the edges of the old CRA which can keep leaking and give rise to further recurrence. So sometimes it is not a bad idea to augment the laser just posterior to the old CRAs. Coming to the final video, here what you are basically seeing is extensive membrane dissection can be really risky, because under oil, if there is a lot of bleeding, it sometimes becomes very messy to go ahead with the surgery. One important pearl that I want to mention is scissors rather than cutters are preferable to cut bands of membranes in under oil situations. So briefly looking at the surgical pearls, keep on injecting intermittently oil to keep up the volume, remove fluid from the interior chamber, retinal surface, and ONH head. Scissors are preferred instead of cutters when you want to do a little bit of membrane dissections and cut the bands, and fluid silicone oil exchange. And usually sometimes we have situations like this. In an under oil scenario, it's an oil-filled eye with a localized RD and a single leaking break in the periphery which is depressible. We can do sterile buckle and we can get excellent results in these cases. You can just put in a localized buckle in that section, do a good first do a cryo, put a buckle, and if the pressure is a little high, you can make a stab incision in the pars plana, drain out little amount of silicone oil to normalize the pressure. How do these patients do? We in Shankar Nethralaya, there was a wonderful study done back in 2002 where about 117 patients were analyzed. Almost 60% of the patients had surgery under oil, and they all did very well. Good anatomical success rate about 62% and a functional success rate of 52.5%. That is well comparable to other recurrent surgeries where the oil was removed. To sum it up, why do under oil surgery? They have less surgical time, less manipulations, and they really good results in selected cases. I really want to acknowledge help to Dr. DAD, Dr. Dhanashri Atra, Dr. Ekta Rishi for their videos, Dr. Saurav and Dr. Bindu, my colleagues. Thank you.